So in this video, I'll talk a little bit about some basics regarding the steps, the assessment procedures that we go through. And again, typically what happens in a clinic is a physician sees a patient, patient has a complaint, or patient was admitted to the hospital. The physician notices that they're having communication difficulties. The nurse reports something. And the physician writes a consult, sends a consult to the speech pathology clinic asking us to assess this person. Okay. Nowadays, because medical records are all electronic, once that consult comes into our clinic and it's divvied up, and let's say I get this consult for an individual who's been referred by his general practitioner or neurologist as an outpatient, I will immediately go in, and my first step really is to do a thorough search and reading of this person's medical history, right? Because at the basic level, the medical history may already say what the disease is. It's Parkinson's disease, in which case I have a pretty good idea that this person's going to have a hypokinetic dysarthria, and they may or may not have some cognitive complaints. Also, if there isn't a diagnosis yet, but there's some neuroimaging, I can look at those radiology reports, and based on where the damage is, I can at least start to be thinking about what kind of tests I want to prepare for this patient. At a gross level, right, left hemisphere damage or atrophy in the left hemisphere is going to suggest language tests, etc., whereas right hemisphere damage may suggest more cognitive-based assessments. Of course, this is a gross simplification. The idea here is something that I said in CD558, which is understanding the neuroanatomy and the relationship between the underlying anatomy and behavior allows you to predict what kinds of problems a patient will have before they even walk into your office. And being able to make those kinds of predictions allows you to be more prepared, both in the tests you pull off the shelf and they're sitting there waiting when the patient walks into your room, but also more prepared in terms of your antenna, what you are paying attention to, what you are looking out for. Because some behaviors are subtle, and if we aren't looking for them, we may not necessarily notice them. And I think that's particularly true with the right hemisphere damaged patients and their communication problems, which are more discourse level, sometimes can be confused with personality issues, etc. Once the person comes into our office, they come to their first visit, and we engage them in an interview. I think the most important thing about that interview process is not the data, the information that we collect. It's much more important for us to establish a rapport with that patient. It's our first experience with us, and we need to recognize that it's a first experience and that they're going to be forming opinions immediately. And if those opinions are negative, then it may be harder for us to change those. But what an interview shouldn't be, in my experience, is a time where we do a very brief meet and greet, and then I go through my checklist of questions to catalog what your problems and complaints are. I think we can quite easily get at that in a much more natural, conversational way that isn't so concretely established, such that I am the expert examiner and you are simply there for the purposes of answering my questions. Right? I think that the other message that sends is that when they are passive and we are just asking questions and going through our tree of questions, that at the end of that we'll know what to do, which is rarely the case. At least that's, I think, the impression we can give patients. I think it's much better if we can begin to establish a relationship where we clearly demonstrate empathy, that we clearly demonstrate overtly and covertly that we think that the patient has their own particular expertise and their own particular understanding of the problems they're experiencing, and that we value that, and we value that because we're in a working alliance. It's not me doing something to you. We are becoming a team, and we each have our roles and we each have our expertise. And so obviously part of that is beginning to talk about goals. On another practical, going back to a more practical level, sometimes medical records are just kind of vague, and so at some point, we can have the patient or family clarify that for us. Of course, I'm diagnosing the patient from the moment I get the consult. Right? That consult may just have a line, 63-year-old man, status post, right frontal ACA, CVA. I'm already thinking, I'm already starting to diagnose. I go out into the waiting room to meet the patient and greet them, see how that goes, watch them walk to my office. I'm assessing what kind of gait do they have, all of this stuff. What was their emotional tone when they were greeting me? And of course the interview, it's all assessment. It's all assessment and rapport building and generating a relationship. There may be times, of course, patients are quite impaired. Either they have a TBI, significant cognitive impairments, they have little self-awareness of their deficits, and we rely more on the caregiver to give us information. I still think it's important that we always at least make the attempt with the patient. And if we can't get it with the patient, that we always ask the patient's permission to talk to their wife and ask these questions. That simple move acknowledges to the patient that they have some control over this situation, that they can exert their autonomy, and that there's a certain amount of respect that you have as a clinician for their underlying sense of self. I have, in CD558, I believe I gave you access to a video that I made that described a little bit how to communicate with people with severe aphasia, and so I've given that information here. Again, it's about a 45-minute video. I think it's something worth, I think it's something helpful. I've always gotten good feedback about it, so I encourage you to take a look at it. It's very practical stuff, and stuff that I think you could start to implement as an extern simply from watching that video. Murray and Clark mentioned doing observations, and what they meant was observing people in their natural environments, in their homes, etc., etc. That's just very, very difficult to do. If you're working in a nursing home, you can observe your patients in the lunchroom, in the recreation room. You can observe them working with other therapists, and that might give you some insight. But in general, it's quite difficult to do something like at-home observations, unless, of course, you're doing home health care, which I think is a wonderful practice to be in because it's so environmentally valid and relevant. Sometimes, before we do our formal assessment, we'll do some type of screening just to make sure that there isn't some other problem, cognitive, linguistic, perceptual, that might interfere with our primary goal of testing. Or we just want to do it to make sure that we don't need to look at that further. So, for example, the comprehensive aphasia test, which I often use as my aphasia battery, has a short cognitive screening in the beginning where I can test for any left or right visuospatial neglect, some nonverbal memory problems, limb praxis, etc. So I'm going to go off the map here a little bit, and I'm not going to say that you always have to give standardized assessments in standardized ways. Because I know that quite honestly, that rarely happens in busy medical and rehab environments where we have limited amounts of time to give these assessments. And B, because it always depends. It always depends. If I have a person who has very mild anomia and the referring physician's question to me is, does this person have aphasia? Well, then yes, I'm going to give the comprehensive aphasia evaluation in its entirety, or the BDAE or something like that, and get a standardized score so that I can compare this person's performance to a normative sample. Because that's the kind of question I'm trying to answer. But more often than not, again, it doesn't take a genius to say that someone has an aphasia. You can spend 10, 15 minutes with 5 minutes with most people with aphasia and know they have aphasia. Purpose of assessment is how can we help them? And so whether to give a standardized battery in its entirety or whether to cherry pick subtests, depends on our purpose. And I think that in the beginning of your career, you probably want to err on the side of giving everything, giving the standardized battery the way it should be given. Because you don't know what you don't know yet. And so giving a comprehensive test allows you to become aware of things that you may not have predicted in testing. Over time, you develop a certain amount of experience and expertise, and you can start to improvise a lot more with your testing. I would say that I'm going to harp on this again. Theory, theory, theory. If you can spend your effort on one thing, it should always be theory. Because theory allows you to understand why you're doing what you're doing. Theory allows you to think about patients who don't fit into nice, neat categories, which many, many patients don't do. Theory allows you to understand why treatments in the treatment literature work or don't work, or why the authors thought they should work. Theory is the foundation. It allows us to construct our own treatments that are not just intuitive guesses. They're our own treatments, they're creative, they're individualized for the patient, but they are also based in some theory which has some science behind it. Test batteries for aphasia, they usually, because aphasia is a multimodality language problem, in a test battery for aphasia we expect that all modalities of language will be tested, usually multiple subtests to assess aspects of each modality of language. In general, if the purpose of the aphasia battery is to diagnose somebody into one of the connectionist classifications, then we expect at the minimum, like in the Western Aphasia Battery and BDAE, to see an assessment of naming, something that allows us to judge fluency, something that allows us to judge auditory comprehension, and a test of repetition. Assessment batteries for TBI and right hemisphere damage, there are not as many of them out there. I've never, quite honestly, found one that I liked. There was always something I liked about this one and something I liked about that one, but I oftentimes don't find them to be have any kind of unifying, underlying, cohesive approach to testing. But normally they cover attention, memory, executive function, and some visual perceptual skills, for example. You should also expect to see, when you do an externship in many medical settings, clinics, SLPs will make their own assessments. And oftentimes what they'll do is they'll pull a subtest or even parts of a subtest from this test, from that test, etc., etc. They'll put it onto their own document and print it out, and everybody in the clinic will do that assessment. There are downsides to that, because these types of assessments often lend themselves more to kind of like checklist type of thinking, which is not a good way to grow as a clinician. But they have advantages too. The advantage is that when everybody is giving the same test, then if I'm covering for another clinician and they just assess somebody and I'm going into the first or second day of treatment, I look at their assessment and I kind of have an idea of what this patient may look like, because I give the same assessment often also. As I have mentioned in the past, I think a test battery is a good way to catalog the map, the terrain of what the symptoms are and how severe they are, and the relative severity of different types of cognitive or linguistic skills. So it gives us an idea of, is there a diagnosis of aphasia? How severe is it? What are their basic strengths and weaknesses? Can we classify them as Broca's, Wernicke's, etc.? But another purpose of a test battery is to give me some idea of what underlying processes, or what are the central causes of these cognitive or linguistic difficulties this person is having. Allows me to begin to form a hypothesis, and in order to confirm or reject that hypothesis, I'm going to need to probably pull some more specific tests or more specific subtests or even informal tasks that I create in order to go through that process. And again, this can be quite lengthy. And I think that as clinicians, we have to be a little bit sneaky and creative in slipping in these assessments, even though technically we might not be billing for assessment, right? In other words, I get my patients, it's a Medicare patient, I've got an hour to do the assessment and write a report. I do it, I start some simple treatment, but it could be diagnostic treatment. I'm using treatment as a way to test too, or I'm starting on a goal that I know is acceptable and reimbursable, but I'm stealing a little bit of time from the session to continue with assessment. And it's not bad to give ourselves a month even and I think oftentimes it usually requires a month or more for this person and their problems to come into focus, right? We get ourselves in trouble when we expect to know, to always know, or to know too soon. When you become really familiar with the research literature, you can't have those thoughts. Because when you become really familiar with the theoretical and the treatment literature, you understand how much they don't know. And so you have some empathy for yourself with that regards too. But if you're ignorant of the treatment research and the science behind the disorders that you're treating, then you may have the distorted idea that you're a failure as a clinician, you should know and you don't. Or even worse, you might have the delusion that you know what you're doing. Okay. Let's go on here. Qualitative assessment. So qualitative assessment, what that refers to is the observations we make of how patients go about doing the tests that we give them, right? What kind of, is my patient really impulsive answering? Are they easily distracted, moving from one subtest to another? Do they have difficulty shifting their attention from one subtest to another? Do they tend to always answer items on the right side of the page, suggesting that they might have a left neglect or some visual, perceptual problem? One thing that we can remember is we should always feel free to step outside of doing a test in a standardized way. In other words, if you want to get a standardized score, yes, give the subtest in the standardized way. Get your score. But then you might want to go back and go through some of those items in the subtest and try to help the patient in certain ways and see if that makes a difference. Cueing them in a certain way, modeling in a certain way. That's all contributes to our understanding of how bad the problem is, the nature of the problem, what we might do in treatment, what kind of compensatory strategies we might be able to construct around these observations, what kind of maladaptive issues are going on that we think are interfering with our patient's performance. And this isn't always strictly behavioral. Sometimes it can be something like just very pronounced test anxiety, or a person being very impatient with themselves, right? Any stressor that a patient puts on themselves is going to reduce their performance. And so sometimes we can improve performance a little bit just by, in the course of treatment, by working with these issues of social anxiety in speaking to others, particularly strangers, how to manage the perception of being under the time pressure to make a decision quickly if you have cognitive impairments, or get your speech out right away if you have aphasia. Caregiver assessments can include appraisal of, getting the caregiver's appraisal of what the problems are. And this is particularly helpful if we want to understand whether or not the patient has an accurate assessment of their deficits. Because normally the way that deficit awareness is tested is you ask the patient a series of questions. There's scales for this. And they rate themselves on their ability to do certain things. And you have someone who knows them very well answer the same scale. And it may be, if you have enough experience with it, as a clinician, you answer the same scale. And then you compare how far away the caregiver and the clinician's scores are from the patient's. Sometimes you'll find that patients think their problems are worse than others think they are. And so there's a psychological component there that certainly is addressable. Sharing results. Sharing results with the families and patients are critical. I can't tell you how many patients I've seen who've, let's say, had aphasia for a year or more, and they still can't tell you, they don't know what aphasia is. They've only heard that they have it. We shouldn't be afraid to give our patients fairly sophisticated descriptions of why they have word-finding difficulties, or why they're having difficulty remembering. As long as we can couch it in terms that are understandable, I think oftentimes our patients and their family members are more than capable of understanding, at least to an adequate degree. And think about yourself. There's a particular kind of mental suffering that happens when you have a problem and you don't know why you have the problem, right? Because when we don't know why we do have certain problems, our mind begins to fill in the gaps with different imaginings, and oftentimes they can be frightful or worrisome. And so in my experience, helping patients, and this is an ongoing process, helping them really understand what aphasia is, understanding that they have semantic impairments and how this manifests in their speech, understanding how other factors, fatigue, anxiety, stress, etc., affect their performance. All of this is part of helping a patient become that other person who can truly be in alliance with you, in forming goals, in giving you good feedback about the treatment you've asked them to do, of truly being a partner, an engaged partner in this process. And of course, easier said than done, but if we can help patients be that, and a lot of times I think they aren't that simply because of the ignorance they're kept in, then we have much better treatment outcomes from my experience.